What's up, guys? My name is John Hawes, RNCCRN with NRSNG.com, where our goal is to give you the tools and the confidence that you need to succeed in nursing school, on the NCLEX, and in your life as a nurse. To help you succeed on this journey, we've created weekly cheat sheets that we send to you every single Friday. To sign up, head over to nrsng.com/freebies. That's nrsng.com/freebies. And every single Friday, we'll send you a cheat sheet on pediatrics, OB, med-surg, mental health, ICU, critical care, every single aspect of nursing care to help you succeed. That's nrsng.com/freebies. All right, now let's roll into the show.
What's up, guys? Welcome to the podcast. This is Katie Kleber. I am your host, and we're going to talk about 7 key time management principles. So I'm going to give you 7 principles, and then I'm going to go over some examples, some nitty-gritty good examples, okay? And I developed them along with another emergency department nurse, Susan DuPont. Oh my gosh, guys, these are wonderful. So let's talk 7 steps. So if you can kind of systematically think about time management, and then as you kind of get this structure, then you can kind of do your own thing. But I think if you have a structure first, then you know what to do. Okay, so number 1, identify the tasks that you need. This will make a little bit more sense when I go through my examples. So identify your tasks. Figure out everything you need to do. It may change as you progress in your, education. Maybe your list of things you're going to do in year 1 is going to look very different from maybe your senior year, but keep that in mind. Create a checklist on your report sheet so you don't forget anything. Eventually you'll be able to remember this all on the top of your head, but not quite yet. So when I was a brand new nurse and in nursing school, I knew I had to do no matter what happened with the patients, I knew I had to chart a telemetry strip, care plan, education, my assessment, and my vitals. So I would write that at the bottom, and as I did those things, check them off. And then when I memorized it, then I stopped writing it on there, but at the beginning it was really helpful. So identify your task as number 1. Number 2, make time. When you're thinking about these tasks, think about how long they will take. As you gain experience, again, they won't take as long, but think about how long roughly it's going to take for you to complete these tasks. Step 3, create a plan. All right, you got to have a plan of attack. And I'm thinking specifically about the period of time right after you get report. Okay, that's what we're going to talk about. I got report. Nobody's dying. Nobody has immediate needs, but I need to look at all of my patients and what is my plan of attack for the beginning of my shift. Okay, so that's creating a plan. So things to consider when you're creating this plan. What kind of time-sensitive things do I have going on? For example, does my patient, are they getting their breakfast tray right now, and do they have insulin due? Time-sensitive. Do I need others to complete something for me to have this? How do I want to say this? Do I need help from someone else to complete this task? So do I need the CNA to be available to help me with a bed bath on this very large unresponsive patient? Or do I need another nurse to sign off on my new PCA cartridge? Those kinds of things. Next thing, do I need to order anything? Do I have what I need in front of me to complete this task? It's one thing if I have everything I need in front of me to complete a dressing change versus, I need to call supply to get a new wound vac thing, or I need to call pharmacy to get these meds. I have to. How much time is it going to take for me to get what I need to complete the tasks? Another thing to consider, is my patient going to be available? Maybe I need to insert a tube, a Dobhoff or a feeding tube, but they have a MRI right now that they need to get. Or maybe I had, when I worked on the floor, I'd send patients to dialysis and they would be gone for 6 hours or 4 or 5 hours or whatever it was. So is my patient, do I need to quickly get some things done for this patient simply because they're going to be gone? So keep that in mind when you're creating your plan. Step 4, group your activities, okay? As you have this plan, think about how I can group things and consolidate tasks. So, example, if 3 patients need their blood sugars and vitals done in the next hour, don't go and do 3 blood sugars on all of them and then go back and do vital signs. Check their blood sugar and their vitals in the same trip. You're interrupting the patient less. You're clustering care and getting things done faster. I don't know about you guys. I was in the hospital earlier this year when I had my daughter, and I felt like, I was frustrated when there would be someone who would come in and leave the room 4 or 5 times, or leave and come back in 20 minutes. Like, I was like, I just want some peace and quiet and to rest. And it's hard to rest when someone's coming in your room all the time. Here's a really common example in the emergency department Susan brought up. A lot of things are ordered at once. So if you know you're going to need to start oxygen, grab a set of labs, do an EKG, and give a couple meds. Get all of that stuff together before you go into the trip. Although, honestly, if they need oxygen, that's probably already in the room. Take that one out. But, if you know you're going to need to draw labs and do an EKG, get all of that stuff and bring it into the room with you. Take the extra, however long it takes to get all those supplies, and bring it in the room and do it at the same time. Step 5, utilize your resources. So if you don't know how to do something, look it up or ask someone where to find that information. Do not waste time aimlessly searching. I remember a coworker had to remove a drain on someone, and he wasn't sure how to do it. And I remember him saying he didn't know how to do it, like kind of in passing, but not like directly to somebody. And he was kind of like aimlessly searching for this policy for like an hour. Like, man. Or I went and I kind of forgot about it. And then I was doing my stuff. I came back to the nurse's station and he mentioned this drain, I think maybe he had to transfer or discharge a patient. I think it was discharging the patient. I'm like, hey, is that patient getting out? He's like, yeah, but I got to take out the drain. I'm like, you were talking about that drain like 3 hours ago. Can I help you? Like, if you would have just came up to me or anyone else and, hey, do you know where this policy is? Oh, yeah. And then helping him find the policy, as opposed to like kind of trying to do it, if that makes sense, trying to do it on your own. Or if you're new and you're about to give a bed bath for the first time, or, if you're new at doing that, ask the CNA what they routinely take in the room with them, instead of grabbing what you think you may need, going in the room and needing to leave and get more things and not even using half of what you brought, those kinds of things. Or if you come across a really weird situation that you don't know how to handle, for example, maybe your patient needs an MRI done, but they have a house arrest ankle bracelet on. How do I deal with that situation? Ask a more experienced nurse on the floor, the charge nurse or someone else, or a different person, and don't just wing it and hope for the best, or, guess. Another thing about utilizing your resources, your computer charting system is a wonderful resource. Being efficient with that, and if you can ask others how to do something kind of quickly, that will help facilitate things. Step 6, roll with the punches. So implement your plan and know when to pivot. Roll up your scrub sleeves and get to work. So start implementing the plan and be ready for that pivot for, hey, this is my plan, and then, oh wait, this happened. You don't want to be so rigid with how you want to do things that you end up being efficient just because you want to do the plan you came up with, if that makes sense. So for example, if you were going to go give your meds for a patient at 1300, you wanted to give them at 1330, but you see that the patient ordered the physician ordered stat labs, maybe at 12:30. Go give the meds and draw the labs in the same trip. So don't be so rigid you can't roll with the punches. Last step: evaluate. How'd it go? Like, did it go the way you wanted it to? Did you do okay? Is there things you would improve? Like, nobody does everything perfectly on the first try. Like, nobody picks up a basketball and with the first dribble is Draymond Green. You have to practice and screw some things up. And if you had a plan and it didn't go great, learn from your mistakes and get better next time. So, or maybe did you learn a shortcut or figure out something that would make it go faster or more efficient? So if you're consistently reevaluating yourself, you'll eventually get to this really efficient person and really good at getting things taken care of. So those are some those were my 7 key steps. So let me just go through them real quick with you. Step 1, identify tasks. Step 2, make time. Step 3, create a plan. Step 4, group activities. Step 5, utilize your resources. Step 6, roll with those punches. Step 7, evaluate. So those are our seven steps. All right, let's go to some examples. These are good. I really love these examples, and Susan helped come up with them. Okay, we've got 4 patients that you just got report on. I'm going to tell you a little bit about each patient, okay? And then we're going to think about how we're going to go through things. 89-year-old, this is patient 1. 89-year-old female who fell, was on Coumadin. CT negative for a bleed. X-ray showed a pelvic fracture of the right ischium. They had 4 milligrams of morphine, 4 of Zofran, and admitted to an ortho floor, but they haven't gotten there yet. The patient just put on their call-light. They want something to eat. There's no diet order, and their vital signs are stable. Patient 2, 81-year-old female with altered mental status. Onset 2 days ago, negative for stroke, and hadn't had a fall. The lab workup shows positive bacteria in their turbid dark urine and a white count of 14. The patient's going to receive a gram of Venk, and after they finish this Zosyn that's infusing, and it's only going to take a couple more minutes, patient's admitted to receive IV antibiotics on the urology floor and have a bed that's ready. Report is called. Transport's going to be there in about 20 minutes. Vital signs, the temp a little bit, 99.4. Heart rate's a little elevated, 94. BP 110/58. No pain, normal respirations. Our third patient is a 40-year-old male with a fever for 3 days. His temp was 102. They received a gram of Tylenol an hour ago and a liter bolus. Temp recheck was 101.9. Lungs are clear. Non-productive cough, sinus pressure. Lab result was negative for flu and strep. Vital signs are pretty normal, except the heart rate is 105. You laid eyes on all 3 of them. You say hi to them. And remember, you're in the emergency department. You just got report on them. You updated them on their plan of care. And we're working on our 7 principles. How are we going to attack this day, guys? We've got 3 patients. First, let's identify our tasks. So patient 1, the only task really there was to get a diet order. So the only thing we need to do, get the diet order and get them some food. Patient 2, get vancomycin, a pump, and tubing. We want to make sure that they are getting their antibiotic on time. Even though they're a pending transfer to the floor, you got a patient with a UTI, we got to make sure they're getting their antibiotics. And number 3, they have a fever and they need a temperature recheck. And if it's still high, they may need some Motrin because they had Tylenol. It's not very effective. Step 2, make time. Need to prepare everything to implement it within the next hour to meet my hourly rounding requirements. And my other patient's going to be leaving in 20 minutes. I'll probably get another patient. Remember, I'm working in the ED. Steps 3, 4, and 5, I'm just going to go ahead and combine them. Create a plan while grouping activities and utilizing resources. We're going to clump that into one. So this is how I would attack that day. The patient's temperature needs to be rechecked prior to talking to the physician because that's the first question they're going to ask. You delegate this to somebody else, tech, medic, something like that. You need to talk to the physician before getting the vancomycin because if they order Motrin, you want to go into the med room and get those at the same time. All this needs to happen within the next 20 minutes because the vanc needs to be hung before they leave. And if the patient can eat and an order is placed, either ask someone else to get that, or grab something from their nutrition room and delegate to the available somebody else to grab a pump for vancomycin. The recheck of the temperature is 101, guys. So let's roll with the punches in step 6. Once you speak to the physician, they order Motrin and another liter of normal saline. The hip fracture person is NPO for a possible surgery, so there's a slight change in plans. So I got to let her know, hey, you can't eat. I'm sorry. This is the change in plans. So I'm not going to get you something to eat, and this is why. Step 7, evaluate. Tough to say whether you could have done some of those differently. it's kind of a personal preference. I kind of like to lay my eyes on all my patients and let them know what's going on so I can kind of have a visual of them so they're not just kind of this person on a piece of paper. However, there could be kind of an argument made for stepping into the fever patient's room and saying hi and taking a temperature, then talking to the physician and gathering meds and hanging the vanc and then informing the NPO and last getting their meds for the fever patient. But to be honest, I'm sure there's plenty of ways to order those tasks that make more sense to other people. And this is why it's vital to figure out what works for you. So let's say we're going from the ED. Let's because time management looks very different on the floor and in the ED and in the ICU. So we did ED. Let's talk floor. You just clocked in and got report on your patients for the day. And here's a little bit about each of them. We've got 4 patients. First one is an 87-year-old male with a stable ischemic right MCA stroke. Came in with left-sided weakness and received TPA. Weakness has improved significantly since admission, but there is some present. Impaired speech. He has a diet which is mechanical soft and honey thick liquids, but no straws. He's probably going to transfer to a rehab facility later today, and you're working with case management. And his family, you're trying to make sure they're set up for the transition. He's got a 7:30 Synthroid due. His daughter is on the phone asking for an update right now, and he's in bed, but he's asked to get up to the chair for breakfast. That's patient number 1. Patient number 2. 38-year-old patient with a history of chronic alcoholism. He was intoxicated and fell and hit his head on the curb. He has a resolving subdural hematoma, which was evacuated surgically 8 days ago. His frontal temporal incision is healing well. He went into alcohol withdrawal 72 hours after admission, but is no longer scoring on the alcohol withdrawal protocol, and therefore does not require PRN lorazepam anymore. His electrolytes are consistently abnormal, and he's flipped into uncontrolled atrial fibrillation with rapid ventricular response 2 days ago. He was put on an amiodarone drip and converted back to sinus, and he's now on oral amiodarone and will hopefully be discharged within the next day or so, but you're a little worried about his home situation. He's complaining about his IV that hurts. It is currently saline locked, and his attending physician is at the nurse's station about to round. That's patient number 2. Patient number 3 is that same 81-year-old female that was in the ED who came in for altered mental status yesterday. She was diagnosed with a UTI and started on antibiotics, as you know, which was done in the ED. Her temp right now is 102.6. Her heart rate is 121. Her blood pressure is 102/72. She's slightly confused, but that's been baseline. She's resting comfortably. Family's asleep at the bedside, and they have no acute concerns. They're not asking, and she's not asking for anything. There are no needs, but you're looking at those vitals and you're a little concerned, right? What do you guys think? You've got an increased temperature, an increased heart rate, and a decreasing blood pressure. Something you should be thinking about with a UTI patient that has those kind of vital signs is you should be thinking about sepsis. All right, guys. Your last patient is a 97-year-old female with advanced dementia and stage 4 cancer. She was admitted to your unit because hospice was full. She is actively dying. She is expected to pass at some point today. She is on hospice protocols, so she is only turned as needed, and a blood pressure and heart rate check is only done once a shift, and when and if the family requests it. The only thing going on with her is she's grimacing and she's diaphoretic. All right, let's work through our time management. Step 1, identify tasks. So for patient 1, we got a med due, a phone call, they want to get out of bed. Patient 2, I got to look at his IV, I got to round with the physician. Patient 3, I'm concerned about her vital signs, so I want to go ahead and look at her vital sign trends, the previous physician notes, and labs, and potentially call the physician. Patient 4, I got to administer some pain medicine, towel off her perspiration, and ask the family if they'd like us to bathe her. So those are the tasks that are in front of me. Okay, how am I going to do this? Make time. Patient 3 is definitely the priority due to her concerning vitals. Everyone else is stable. However, patient 2's physician is actually there, and patient 4 needs pain meds now. So let's go to steps 3, 4, and 5. I'm going to make a plan, group activities, and gather my resources. So the way I would personally attack this situation at the beginning of my shift is I would let the medical unit secretary inform the family that this patient had an uneventful night and to call back in about an hour for a more detailed update. I would delegate getting him out of bed to the CNA, and I would grab his med that's due when going to the med room to get the pain med for patient and for patient number 4. I would quickly round with the physician for patient 2 and look at his IV while I'm in the room with the physician. I would grab the pain med for patient 4 and the Synthroid at the same time. I'd go to patient 4's room to administer the pain med and towel off the patient with a cool cloth and inquire about the bath. On the way back to the nurse's station, I would go into patient 3's room and do a full assessment. I'd review her chart in the room. When I got back to the nurse's station, I would page the physician, and while I'm waiting for the return call, I would chart the assessment I just did. Once that is done, then I would go back and administer the Synthroid. But let's say I'm implementing this plan. All right, so I'm rolling with the punches. That CNA that I wanted to delegate to, she's not available. So I let the patient know that I'm going to go check on my other patients and I'll be back shortly to help him up. He's slightly annoyed, but this is the priority right now. So I continue with my plan. After the return call is received from that physician about the concerning vital signs, and I have a few orders, I go administer that Synthroid to patient 1 while I wait for these orders to be verified from a pharmacist, because typically physicians put in an order for maybe a medication, and a pharmacist typically looks at that order before the nurse can pull the medication. So I have to wait. I can't just go pull it out real quick. I have to wait anyway, so I might as well maximize my time. As I go into the room for patient 1, the CNA, I see that they beat me in there, and they're actually walking him to the chair as she suddenly became available. This enables me to just go ahead and start administering the Synthroid and complete a quick assessment, and then go grab my newly verified meds for patient 3. Here we go. How did I do? Step 7. Well, it probably would have been better if before I got report, if I saw that patient 1 had a Synthroid due right away, because I would have honestly grabbed that and given it to him mid-report. There could be an argument for me dropping everything and whenever I noticed something with patient 3 was off. However, balancing the tasks that I needed to do for them while I was balancing the tasks for my other patients while I'm kind of doing those very important things for 3 enables me to not be totally behind and not have dead time on my other patients when I could kind of get both things done at the same time, if that makes sense. So once patient 3 was situated and taken care of, everyone else was caught up instead of being like 2 hours behind, if that makes sense. All right, so that was the floor. Let's talk about the intensive care unit though. Okay, so typically in the intensive care unit, you're going to have 2 patients. So that's going to be our situation here. So I've just received report. I'm going to give you a little information on both of them. Patient 1, 72-year-old male that was found down and unresponsive yesterday. He was brought to the ED via an ambulance, and a CT scan revealed an extensive intraparenchymal hemorrhage. His blood pressure was 254/109 on admission. He was immediately intubated as he was not protecting his airway. He's currently on 15 milligrams an hour of nicardipine with an order to keep his blood pressure less than 150. He's intubated, sedated with propofol with a RASS of -2, and he's ordered to be at -2. He has a central venous catheter in his subclavian. His blood pressure is 142/86. His heart rate is 92, and his oxygen is 100%. You have an order to insert a feeding tube. Start tube feedings, administer 40 milliequivalents of oral potassium and 25 milligrams of low pressor down this tube, turn him and assess him. Oh, and his wife is on the phone. Let's talk about patient 2. This is that same little 81-year-old, guys. She got to the ICU. She was bad news bears. That same little 81-year-old female is in septic shock in your ICU. She was urgently transferred to the ICU overnight after she was unresponsive to fluid boluses on the floor and had a decreased level of alertness. She was intubated upon arrival to the unit, and a central line was placed. She is on 0.4 of vaso and 5 of Levophed in order to keep her MAP above 65. She has an antibiotic due and a follow-up lactic acid to be drawn and sent to the lab in the next 15 minutes. Her family is emotional and at the bedside. Her current blood pressure is 95/44. Her heart rate is 110. Her oxygen is 96. Her temp is 101.8. You do have an order to administer a Tylenol suppository for any temperature over 99.2. All right, you just got a report. You just walked into work. that's what's going on. Honestly, it's a pretty typical day. All right. Identify tasks. So for patient 1, the things I need to do: place the feeding tube, verify the placement, administer the medications, talk to the wife, assess the patient, and turn the patient. Oh, and document all of that. Patient 2, what do I have to do? I have to draw and send that lab. I have to administer and hang that antibiotic. I have to titrate the Levophed. Remember that blood pressure was 95, I believe, 95/44, which I believe that makes that MAP like 60. I don't know it off the top of my head, but I know I wrote that where the MAP is low. So I have to titrate my Levophed up. I also have to administer a Tylenol suppository. So those are my my tasks. Step 2, I got to make time. So I'm going to let the medical unit secretary take a message from bed 1's wife. I do not have the time to be on the phone with her right now. I've got too much pressing stuff going on. Patient 1 is a little more tasky and stable, while patient 2 has some immediate priorities. Unless patient 1 has a spike in blood pressure, patient 2 is the priority. So let's combine 3, 4, and 5. Patient 2, again, is the priority. I'm going to increase the Levophed to 6 while I'm in the room. I'm going to go to the supply room and the med room and grab the Tylenol, lab stuff, and antibiotic. I'm going to go back into her room, draw her lab, administer meds, and complete an assessment and turn kind of all at the same time. After all of this, I'm going to check another blood pressure. It's now 102/58. All right, so I drew my lab. I'm going to go drop it off at the tube station and grab the feeding tube for placement on bed 1, or patient 1. I will ask the coworker to meet me in that room in a few minutes to help me kind of hold the patient in position. I'll place the feeding tube, assess him, turn him on his side, and when I'm done, I'm going to look at the blood pressures for patient 2 to make sure that they've continue to go up. If it's okay, if that other patient's doing okay, then I'm going to chart what I did and then order x-ray verification placement of that tube. All right, after I get that done, I'm going to go back into patient 2, chart my assessment, and see if the lactate level has come back. And if enough time has passed to enable me to recheck a temperature, I will do so, but I will chart at the bedside just to be right there. Step 6, let's roll with the punches. How did things go? So I increased the Levophed for patient 2, and I grabbed the feeding tube for patient 1, and I checked the chart to verify the order of placing the feeding tube. So that's something you really need to make sure you do. If you got report on a patient and the night shift or the previous shift said, yeah, you need to insert a feeding tube, I didn't have time to do it, you don't just go do it, you double check the order. So I went to the computer, double check the order, and I see that the patient has a history of a sinus surgery 6 days ago. So if I'm inserting a tube in their nose and they just had surgery up their nose, that is a major contraindication. So I'm going to page the physician who changed those oral meds to IV and requested medical records to see if this about this recent surgery. It's most likely not going to be safe to insert the tube. So instead of inserting the tube, I assess and turn the patient and chart on him. Then I go check on patient 2 and complete the tasks that need to be done there. And after I'm done with patient 2, I'm going to go back to patient 1 and administer the newly ordered IV medications. Since you were caught up and they were both stable, you called patient 1's wife back and provided an update. Step 7, let's evaluate it. How did it go? So it would have been helpful if you noticed the recent sinus surgery earlier in his chart, or better yet, if the physician would notice that. But since you were in the room already, you went ahead and quickly assessed and turned him. But honestly, you probably could have stayed in the room with patient 2 until she was completely squared away once you realized you couldn't place the tube. But, you know, c'est la vie, right? So that's 3 examples of ways to manage your time in very practical situations, okay? So use our principles, and I'm going to go over them again one last time. So identify tasks, make time, create a plan, group activities, utilize your resources, then roll with those punches, and then evaluate how you did. So I hope this helps with your time management, whether you're in the ED, the floor, or the ICU, and you're able to kind of rock through all of your shifts. So thanks, guys. Thanks for listening.
All right. I hope that was helpful today, guys. I hope that gave you some motivation, some inspiration to go out and to be your best self, to go out and to become the nurse that you want to be, to make a difference, and to do the best work that you can. Listen, we're here to help you along your way. At nrsng.com, our goal is to give you tools and confidence to help you in nursing school, on the NCLEX, and in life. One of those tools we created is our Friday freebies, these weekly PDF cheat sheets that you can refer to on the clinical floor, in the classroom, and just throughout your entire career as a nurse. To get these cheat sheets, head over to nrsng.com/freebies. That's nrsng.com/freebies. You guys, if you need anything, we're here for you. You can reach out to us on social media or via email at contact@nrsng.com. We want you to succeed. We want to help you along the way. We're here to hold your hand. We're here to give you the tools, the confidence that you need to achieve success in this journey to nurse. All right, so you guys know what time it is now. It's time to go out and be your best self today. Happy nursing.